Hi, everyone. Thanks for your patience. So today we're going to be talking about the Patient Protection and Affordable Care Act, sometimes called the Affordable Care Act. I will probably be calling it the ACA. It has other names, but I like to call things by their actual names. So this is kind of very basic level stuff. Just to make sure everybody has their bases covered, make sure you understand what the Affordable Care Act is, what the major provisions are, how it affects things, and then how it's been changed over the past 9 years. It was passed by the 111th Congress, March of 2010. Medical spending in the government really didn't start from a large scale until the 60s. That's when Medicare and Medicaid were expanded to everybody. This is the biggest expansion of that since the 60s. So one could argue the second biggest expansion of medical government spending in US history. For some context as to why it was passed, prices have been going up and up and up, really ever since the 50s, and there's lots of interesting historical reasons why that happened that I'm not going to get into right now. But basically, of other, industrialized nations, we spend about twice as much per capita. Most of our outcomes, meaning like, lifespan, health outcomes, general, incidence of chronic diseases, that kind of thing, those tend to be worse in America than our peers. So anyway, things are going up a lot. We're going to talk a little bit about universal health care. The first thing is the Affordable Care Act was not an attempt to pass universal health care for a couple reasons. But we'll talk about those in a second. So historically, the United States, and by the United States I mean the government of the United States, has tried to pass universal health care about 6 times. It started around the 19-teens, and the most recent one was during the Clinton administration in the early 90s. So those are all the times that we've attempted to pass universal health care, and it's never passed. That being said, most people don't understand that we already have universal health care in the United States. It's an interesting debate that people don't understand that this is already the context. So in the United States, no matter who you are, no matter how much money you have, if you go to an emergency room, you will receive medical care. They cannot kick you out. And if you can't pay that bill, that's on the government. That goes under Medicaid's budget. That is by definition universal health care. So the United States has universal health care. It just happens to apply to one type of place. And that type of place also happens to be the most expensive form of health care that our system provides. About 1 in 5 adults in, I think 2010 is my stat, in 2011 used an emergency room. And emergency room visits counted for 1/3 of all healthcare costs. And this is a thing that is ostensibly universal, right? Luckily, plenty of people who go to the emergency room can pay via insurance, but we do already have universal health care in place. Now, what we don't have are systems like, and there's different types of universal health care. In Britain, they have the NHS. That's basically about as universal as you get. So they basically treat medical care like the police or like the fire department. The providers are government employees. They're paid for by taxes. It doesn't cost you anything to have a cop show up at your door. It doesn't cost you anything to have a fire person show up at your door, at least at point of service. There are other versions of universal health care, like Canada, France, and Australia, lots of places. They basically have a combination of the people or the institutions that give you the health care are private, but the way it's paid for is through a single payer system. That's the one that most people who advocate for universal health care in America are thinking of, although not everybody, there's plenty of versions. So we do have universal health care in the United States. It happens to be the emergency room. And that's covered under Medicaid. So we're going to talk about what I call the Affordable Care Act Classic, the ACA Classic, which is what was originally passed, what it was intended to be or intended to do. And then we'll talk about Diet ACA, meaning what's changed in the past 10 years. Because currently the Affordable Care Act, I mean, it's an act, but its instantiation in 3 dimensions is not what it originally was meant to be. So, ACA Classic. ACA had 2 broad initiatives, and they're different in type, so we're going to talk about them separately. The first is changing insurance. So again, not changing healthcare here. This is changing insurance and changing the way healthcare is paid for, and then changing delivery, the actual healthcare. It's important to keep these things separately always whenever you're having these discussions, because often they tend to be conflated and they shouldn't be. So with the insurance reform, we'll talk about, basically the gist is easy. They wanted more people to have insurance, and they wanted the coverage to be better. So here's the more people part. I'm going to dive into theory a little bit here. I hope that's okay, but it's going to make everything else clear. I like to invest the time up front. So there's the Medicaid expansion. If you've been to the Medicare, Medicaid, and CMS course, you know about that. Basically, different states have different thresholds in which they give someone access to Medicaid. Part of the Affordable Care Act was saying, you know, we're going to have a higher threshold and it's going to be independent of states. So more people can access Medicare or Medicaid. Dependent coverage age increase. Now, it used to be back in the day that if you were over 18, you were off of your parents' coverage. There were some exceptions, like if you were still in school, they were able to make some exceptions. But most universities, as part of their student package, provided insurance. Like you got university insurance as a student. Now that's not really on the table anymore. I mean, it's still possible, but it's not really on the table anymore because parents can keep students on or kids on up until 26. At this company, that's a very live issue. At least once a month, I get someone aging onto our plan. Then there's the insurance exchange implementation. Again, the idea here is getting more people insured. And so there are plenty of places in this country that don't look like Massachusetts where there aren't a lot of options, both for healthcare or for insurance. You basically have one choice, and if you don't like it, sucks to be you. So the idea was to implement a digital exchange, basically an Amazon or whatever, for insurance companies where you could compare prices, pick a plan, basically make it easier for people to access insurance. And people who, the exchange also subsidize people who don't make a lot so that they can get insurance at a more affordable rate. So it's a combination of making it more affordable, which allows more people to have it, and making it accessible, which allows more people to get it. Then there's the composition expansion. When I say composition, I mean composition of the insured pool. So the composition of the people who are insured. And this is where I get into theory. So there's guaranteed issue, which means you are guaranteed to get insured. You will get insurance. Up until 2010, that was not a guarantee. If you had some kind of pre-existing condition, sucks to be you. At the very best, you could get specialized insurance. That's like if you have, you know, type 1 diabetes, you could pay 5 times what everybody else paid to get your special type 1 diabetes insurance. But for most people, that equated to not having insurance, financially speaking. Community rated premiums. Up until 2010, if you were not in an employer insured environment, if you were getting your own insurance, it was priced to you, to your problems, to your issues. Again, not great for someone who doesn't have perfect health. But now you are rated based on a group that you're in, whether it's, you know, it's a combination of income and economic and age and gender and all that fun stuff. And the last thing is individual mandate. This is saying that, again, expanding the number of people who are insured, this is saying everybody needs insurance, and if you don't have insurance, and we're providing you lots of ways to get it, if you don't have it, you pay a fine once a year to encourage people to buy it. Because you're either throwing some fine away, or you can spend some of that fine on insurance. Now I'm going to talk about composition for a second, or I'm going to talk about theory for a second. So in most big, scary things, there's a triangle of trade-offs. In healthcare, I've heard it referred to as the iron triangle. There's a similar one for project management, incidentally. So the trade-off is you can increase one of these things, and as a result, probably two are going to decrease a little bit, or you can increase two of them, and the third one's going to decrease a lot, and vice versa. So for cost, you can increase cost, and then quality might decrease, and access might decrease a little bit. Access means who can get it, who can use it. You could increase access a lot, so everybody has it, but that means either cost is going to go up or quality is going to go down. You could make quality skyrocket, but that means either access is going to go down or costs are going to go up. You get the idea. You cannot have all three improve at the same time. You cannot have better quality, lower costs, more access. You get to pick. Now you can change based on the situation, you can change based on the type of care, you can tweak, but this is an inescapable reality, right? So this is what you will constantly see, not just the Affordable Care Act, but for the rest of your lives, be a struggle. The second part of insurance, which is theoretical, is the concept of asymmetric information. And asymmetric information comes into effect in two different insurance lingos. One's called moral hazard, and the other is adverse selection, okay? And you don't have to remember all this stuff, you'll get the theory. So in my example, we have a classroom of students. This is my classroom and I'm a teacher, right? And at the end of the year, you get a grade, right? And so this is a grade, failing to 100, right? So if I was a person who really cared about my grade and I want to have a good one, but I'm not a fantastic student, I might want to get grade insurance. So let's say there's an entrepreneur in the class, they're going to offer grade insurance. And they say for $50 a class, a course, I can guarantee you one increased grade letter. They have a shady back-end deal with the teacher. So that's great. So I'm a hardworking student, but I'm not a genius. I might get a B, I might not get a B, and I want to get an A. So I'll buy that insurance. Or I'm a very lazy student, but I'm actually kind of smart, so I can use this as an excuse to be lazy and make sure I get a better grade than I would otherwise, and so on and so forth. There's lots of scenarios in which someone would use this grade insurance. So the issue with asymmetric information is, I, the person offering this shady insurance, I don't know anything about the individual people who are going to buy that insurance. I don't know anything about you. I don't know if you're a really good hardworking student who's just being safe. I don't know if you're a very lazy student who wants to piggyback. I don't know anything about that. So the information is asymmetric. The student knows more than I, the insurer, do. Yeah. So what happens is there's two things. There's adverse selection. Adverse selection means too many of the wrong type of people buy my insurance. Meaning that if only bad students buy my insurance, then I'm going to have to pay the teacher a lot of money because every single one of them is going to need it. Whereas if only good students buy my insurance, I get to keep all their money and never have to pay the teacher because they get A's anyway. Make sense? So adverse selection is a situation in which only bad students buy my insurance, and I have to pay out all money or lose money. Then there's moral hazard. Moral hazard's not about the pool you choose. It's about the very fact that once someone gets insurance, they change their behavior, right? So if no such thing as grade insurance existed, then someone would work hard or they wouldn't. They would just be their normal selves. But there are edge cases, right? Someone who usually gets a B, who might work hard to get an A in the class, but if they have insurance, they might not work hard at all. So moral hazard is when I change my behavior because I know I'm insured, because I have this safety net. And so you could have a situation in which your group selection is fine, which is the adverse selection. Your group selection is fine, but because people know that they have a safety net, they start to be a little bit more reckless. And again, that's because they have all the information. They know what their habits are. I, the insurer, don't. Does that all make sense? Okay, that's all the theory for now. But again, now you understand, we'll talk about that in a second. Now you understand why all these things have to happen, right? So the composition selection has to change because you want to get as many people in that pool as possible. You want to get as many A students in that pool as possible and as few, C and D and F students in that pool as possible. Because otherwise, you're going to go broke, paying the teacher, so to speak. And community-rated premiums, that helps you avoid these kind of things where I don't know about you personally. So in order to get everybody on board, I have to just give a blanket rate to some number of people. And the individual mandate, again, trying to get those A students on in my analogy. When we talk about the exchange, the insurance and exchange implementation, I talked about a little bit how they account for income. This is a quick chart, and again, all these are available on the internet, so you don't need to memorize it, but the gist is, here's the percentage of income you're at relative to the federal poverty line. And they said you're not going to spend more than this percentage of your income on premiums. So even if the plan that you're signing up for costs $10 million a year, you yourself are not going to pay more than 3% or 9.5% or whatever of your income. And the difference is dealt with by the government one way or the other. So that's the concept behind the subsidies in the exchange program. You hear subsidies, that's what they're talking about. Okay, so that's the more people part of the Affordable Care Act, the ACA Classic. Next is better coverage. So the better coverage, there's a few different items here. So there's EHBs, essential health benefits. What these are is a list of things that all insurance plans have to provide, period. If you're going to be an insurance plan, you got to have this stuff. So let's see, some ones are inpatient care, outpatient care, emergency services, maternity and newborn care, mental health, prescription drugs, rehab, lab services, chronic disease management, and pediatric services. Now, to be clear, EHBs are not, this is all free. It just means your plan covers them in some way. Plans can be structured in many different ways. But all health insurance plans since the Affordable Care Act cover those things in some way. Okay, so the next is preventive care. Preventive care is different from EHBs. This is not saying, preventive care is stuff that you don't pay any money for at the point of service. The idea is, if we're spending all of our money in the emergency room and all that's increasing the federal expense, then the idea is to keep people out of the emergency room, right? Unless we're going to scrap our universal health care of emergency room point of access, we have to keep them out of there or let them die. Those are our two choices. So in order to keep people out of the emergency room, we try to make sure they're healthy. And the best way to be healthy is to never get sick. So preventive care is the stuff that keeps you from getting unhealthy. Make sense? So preventive care items are free. They're trying to get rid of any barrier. So for some people, a $20 copay is a very big deal. And so they're trying to make it so that is not a reason not to go to the doctor. Still plenty of other reasons not to go to the doctor, like you don't have paid time off or not a doctor within 30 miles of your house, but that's not what we're talking about right now. So preventive care stuff is free at point of service. So that includes mammograms, colonoscopies, your annual physical, gestational diabetes screening, STD and STI screening and treatment, contraceptives, and other things like that. Next is adding pharmacy benefits to Medicare. Again, we've moved on from increasing the pool, now we're making the care better, or at least the coverage better. So Medicare used to only have, so again, watch the Medicare, Medicaid video if you haven't yet, but Medicare has different types, type A, B, C, and D. And for some, if you only have some of those types, you're on the hook for your pharmacy costs. Unless you have type D, you don't get any pharmacy benefits. The Affordable Care Act changed that a little bit, and it said, even if you only have the basic Medicare, which is technically A, but most people do A and B, even if you only have the basic Medicare, the government will cover 50% of the cost. So it's definitely not life-saving, but it's something for the people who have decided they can't afford Part D. Cap changes. So there used to be a cap, there's no longer a cap, called a lifetime spending cap. So, you have your annual amount the insurance company is going to cover each year, but they used to have a lifetime amount for every individual person that followed you around, whatever doctor you went to, however many years you were with the insurance company. And let's say your lifetime cap was $1 million. So once the insurance company spent $1 million on you, you're done. You're not getting any more money from them. Obviously, that's a very big deal for someone with a chronic or acute life-threatening illness like cancer, because those treatments are like 20, 30 grand a pop. So that cap was removed. No more lifetime caps. Lifetime caps are illegal. And they introduced a new cap called the out-of-pocket maximum, annual out-of-pocket maximum. It used to be the case that not only did you have a lifetime cap, you also, even if you had insurance, and this is when you hear all the stories of people with medical insurance who were going bankrupt, even though they had medical insurance. Even if you had medical insurance, after you hit your deductible, you're still usually on the hook for like 20% of your expenses, stuff like that. And again, if you have a chronic or an acute life-threatening condition, 20% of $1 million, still enough to make you go bankrupt. Don't worry about that. We don't have a 20% thing here. Definitive Healthcare covers you 100% after you hit your deductible. So we removed the lifetime maximum cap, and then we added the out-of-pocket max, which basically says every year you have a limit on how much you can take out of your wallet and give to a healthcare provider. At Definitive Healthcare, it's like $10,500 or something like that. You'll never get there. And the last is administrative simplicity. This just encompasses a lot of stuff, but let's see what else. There's like transparency about premiums. You guys, some of you might remember that the this is not a bill statement and the breakout, those weren't around 10 years ago. You just kind of more or less got a bill and you had to suck it up. It wasn't very clear if you got a bill at all. Yeah, so that's how they tried to change insurance. So they tried to make it available to more people, and they tried to make the insurance itself better. Next is delivery reform. So the idea here was, or the main notes that were being played were integrated care, quality, and innovation. This is where a lot of the stuff in our database comes from, by the way, or at least some of the stuff in our database comes from. So with integrated care, bundling payments became a very big deal. We have the CJR and other programs that basically made very common procedures bundled together rather than fee-for-service. Fee-for-service had slowly been going out of style around the late 80s and early 90s. Of course, it came back in the early aughts, which is kind of why we're here right now. But this really incentivized hospitals and other care providers to treat things as a disease rather than a treatment. The structure of an ACO is introduced. ACOs are very interesting because Medicare and Medicaid really limited the amount of fee-for-service stuff it would pay for. So they bundled payments, which means there's no longer fee-for-service, right? But you could form an ACO in which you still get reimbursed in a fee-for-service method, but ACOs are held to different standards than other medical care providers. So like if an ACOs have to report a lot more metrics to the federal government. And if they fall below certain thresholds, they get fined. That doesn't happen with regular healthcare providers. They just have to deal with the other issue of they only get so much from the government and they have to balance their budget. The ACOs, they can charge differently, but they're held to a different standard. And then community transition. This is the introduction of, if you're the integrated care is, you're leaving a hospital, you go to a rehab, then you go to a home care health aid. That was really made a lot more robust during the Affordable Care Act. Focus on quality. We introduced all these quality measures, again, a lot of which live in our database. The hospital readmission reduction program, where if you go in for a heart surgery and then you get released into the wild 7 days later and you go back in the hospital for a heart problem, the hospital doesn't get paid twice for that. They only get paid the first time because ostensibly they should have done it right the first time. Transparency and data sharing. This is where a lot of the mandates for the electronic medical records and all that other stuff came up. We want to digitize records, make them very transparent, make them very clear. And so then there's also value-based purchasing. This is where you get the HCAP score, other scores that Medicare, Medicaid, CMS rates you on, and then adjusts payments based on that. So this is the integrated care and also innovation. They are trying new things. There are FQHCs, federally qualified healthcare centers. Those are more often set up in rural areas that don't have a lot of choices, but these are basically places that have, again, very high standards, very rigid standards, and they offer complete care in kind of one location: dental care, OB/GYN care, GP care, all that fun stuff. So they're really trying to innovate there, especially with communities with low access. They created the CMMI, which is the Center for Medicare and Medicaid Innovation. And generally the CMI before the Affordable Care Act was about $1.1 million budget. After the Affordable Care Act, it was about $2 million. So they doubled that, which is, as far as the government's concerned, peanuts, but it's still twice as many peanuts. And they also are doing a lot. They tried a bunch of other things like bidding, pricing, auction styles, and stuff like that, which I'm not going to get into. So part of the Affordable Care Act that isn't often talked about is they're trying out new ways of delivering health care. So this is the timeline for ACA Classic. It was passed in 2010, but it wasn't like all of this stuff, all these major overhauls were going to happen immediately. So a lot of the regulatory stuff, like insurance has to cover X, Y, Z, you can't have caps anymore, that more or less went into effect immediately. At the end of 2013, exchanges went live. About 15 states had their own exchanges. Everybody else got to use the federal exchange. Because the exchanges were live in 2013, on January 1st, 2014, the individual mandate was made live. Oh, no, that's not right. Individual mandate was, 2014. And then in January 1st, 2014, a lot of the other provisions went into effect, the Medicaid expansion, stuff like that. The last kind of thing that would happen in the Affordable Care Act implementation was the Cadillac tax, which is a nickname for basically the government would tax very, what they considered excessively rich benefit plans, excessively rich insurance plans. What's interesting is the definition of excessively rich insurance plan in 2010 is kind of a passable insurance plan in 2019, but they didn't know that at the time. So, and then by January 1st of 2020, everything would be live and it would all be wonderful. So that's the ACA Classic timeline. Questions about implementation? Cool. Oh, there's one more thing we didn't mention, which is who's going to pay for all this? How's it going to get paid for? This is a big part of the Affordable Care Act, right? If we want to increase access, which is one of these things, and increase quality, which is the other of those things, we know from the Iron Triangle that costs are going to go up because has to happen. So how are we going to pay for all this? We're going to do it by a combination of fines, taxes, and reduced spending. Yeah, there we go. So fines are the mandates. There's an individual mandate, which you talked about. If you don't have coverage, you get to pay some money to the government every year. For an individual, it's about $600, and for a family, it's about $2,000. Capped at a certain percentage of your income. Then there's the employer mandate. If definitive healthcare didn't offer a good enough plan or a good enough plan at an affordable rate, we would be penalized financially. And that's actually was still in place until very recently. Like, even if we offered a great plan and you decided instead to use a federal or state exchange, if too many people in our company did that, we would be scrutinized and eventually fined because something's off. So that's the fine part. Taxes are increased payroll tax on high wage earners. In this scenario, high wage earners means individuals who earn $200,000 or more a year, or couples that earn $250,000 or more a year. They would increase their payroll tax, their marginal tax, so the amount above $200,000 or $250,000 would increase by 0.9%. There's also introducing a tax to unearned income. As you hopefully noticed, because you look at your pay stubs regularly because you're a responsible adult, that you pay a Medicare tax on your paycheck. Half of it's paid for by definitive healthcare, half of it's paid for by you. That's true, and has been for a while, for earned income, for paychecks. But on unearned income, meaning investments, interest, capital gains, you don't pay basically any taxes on that, and that doesn't help Medicare or Medicaid out in any way. So what the Affordable Care Act said is, all right, starting January 1st of 2020, even capital gains get the exact same, so no more, no less, the exact same Medicare tax as earned income does. So all income gets taxed, not just earned income. And that would be about 3.8% on capital gains. Then there's the point of service tax on various health-related activities. So certain activities that are either very expensive or not good for you would receive a higher tax. In the same way that we tax cigarettes, right? We tax alcohol. Certain things would be taxed more. So there would be a 10% tax on tanning salons, stuff like that, because that would probably make you go spend healthcare money later on in your life. So we want to extract some value from that. Other ones are very high level or high cost things. Importers and manufacturers of prescription drugs. So right now, imported drugs are very cheap, largely because we don't tax for them. So there would be a tax on that. Certain medical devices, we'd start to have a tax on that. And then again, the point of service of stuff you access. So those are all the taxes. And the fine part really is only going to pay for a small portion of the Affordable Care Act. The taxes are going to pay for the majority of it, and the rest is paid for by reduced spending. So that means that CMS is going to lower how much it pays out to hospitals and doctors. And we're also going to be administratively smarter and consolidate all the federal loan programs into the Pell Grant program. We're going to consolidate CHIP, or the Children's Health Program, or SCHIP, State Children's Health Program. We're going to consolidate those into Medicaid. Again, try and save some money by administrative efficiency. So combined, that was supposed to take care of the rising cost part, right? Because we had to satisfy the iron triangle. This was our tribute to that god. So that's ACA original, ACA classic. Of course, that was what was passed in 2010. It is now 2019. Basically 2020 at this point, let's be honest. So a lot of things changed in the intervening years. And I'm going to talk about these very quickly. Basically right after the Affordable Care Act was passed, if you were even remotely politically conscious at the time, you knew that it was fought immediately after passing. And generally speaking, the party that was against it had a minority in every kind of government branch, with the exception of the judiciary branch. So that tended to be where they fought it, in the place where they had the majority. So right away, I think in about 27 states, different suits were brought up to try and overturn the Affordable Care Act. There's one that made it to the Supreme Court. And when I say there's one that made it to the Supreme Court, that's always a weird thing to say, because the Supreme Court usually only takes cases where there's conflicting rulings in different circuit courts. So even though one is like the avatar that made it to the Supreme Court wouldn't have taken it if there weren't lots of different conflicting rulings in the circuit courts. So just keep that in mind. But the one that made it to the Supreme Court is known as Sebelius, or NFIB versus Sebelius. Sebelius, actually, you know what? I'm going to stop talking. I'm going to play the video. Now, this is a very informative video by a person with very deadpan delivery. So try and get past that. Hello.
In 2010, Congress passed a controversial healthcare law, the Patient Protection and Affordable Care Act, popularly known as Obamacare, or otherwise known as the ACA. Shortly afterward, multiple parties, including business organizations, individuals, and 26 states, filed suit in district courts across the country to challenge the act's constitutionality. The results were fractured. Some courts upheld some or all of the ACA, others declared part or all unconstitutional. Some concluded offending provisions could be severed, and others argued that the act couldn't be challenged until someone was forced to pay the penalty. In National Federation of Independent Business versus Sebelius, the National Federation of Independent Business, the state of Florida, and other plaintiffs sued in Florida federal court Catherine Sebelius, the Secretary of the U.S. Department of Health and Human Services. The ACA is a massive piece of legislation, but the litigation challenged two key provisions. One, the individual mandate, which requires individuals to purchase health insurance or pay a penalty. And two, the Medicaid expansion provision, which conditioned continued receipt of federal Medicaid funds on states expanding their eligibility requirements for the program. The district court held that Congress had exceeded its authority in passing the individual mandate. The court concluded that the individual mandate was not severable and struck down the act as a whole. On appeal, the 11th Circuit Court of Appeals affirmed that the individual mandate was unconstitutional. However, the Court of Appeals determined that the individual mandate was severable, so the rest of the act remained intact. The Supreme Court agreed to hear the case to resolve the split between the circuits. Chief Justice Roberts, writing for a divided majority, found the act constitutional in part and unconstitutional in part. Roberts first concluded that the individual mandate could not be justified as a valid exercise of commerce power because the Commerce Clause did not empower Congress to compel individuals to engage in commercial activity. Further, Roberts concluded that the possibility that people would participate in the healthcare market at some point in the future was not enough. Roberts viewed this as a slippery slope that would open the door to congressional regulation of all sorts of activity or inactivity not contemplated by the framers. To illustrate this, Roberts said that obesity was more responsible for increased healthcare costs than uninsured people, but under the government's theory, the federal government could mandate that people buy vegetables. Next, Roberts wrote that the necessary and proper clause only gave Congress the power to do things that were incidental to the valid exercise of some enumerated power, and therefore the individual mandate could not be justified on this ground either. However, Roberts reasoned the individual mandate's penalty provision operated more like a tax imposed on those opting against purchasing coverage. Because the tax was assessed just like other taxes based on income and collected by the IRS, the fact that Congress had called it a penalty was irrelevant. The court interprets legislation as constitutional if fairly possible, and the individual mandate could be saved by interpreting the penalty provision as a tax. With respect to the Medicaid extension, Roberts held that the federal government could not withhold existing Medicaid funding from states that chose not to participate. Roberts acknowledged that Congress could offer grants to states and condition the funds on compliance with certain requirements, as happens frequently with highway and infrastructure funding. However, Roberts found that the act did not offer the states a genuine choice, because they must accept the basic change in the nature of Medicaid, or risk the loss of all Medicaid funding. Accordingly, the Medicaid provision was found unconstitutional. The majority found the provision severable from the remainder of the act, which was left intact. Justice Ginsburg concurred in part and dissented in part, concluding that the individual mandate should be upheld under the Commerce Clause, because there was a rational basis for Congress to believe that the large uninsured population substantially affected interstate commerce, and that the mandate bore a reasonable connection to addressing that problem. Ginsburg disagreed that the Medicaid expansion was unconstitutional. Ginsburg found that the states had no existing rights to federal funds, and that Congress could decide whether federal funds should be given to the states and under what conditions. Justice Scalia dissented, writing that the entire act should be struck down as unconstitutional. He argued that neither the Commerce Clause nor the power to tax and spend granted Congress the authority to require the individual mandate. Scalia further argued that the Act's threats to terminate states' Medicaid funding absent compliance with the Medicaid expansion were impermissibly coercive. The Sebelius decision, particularly the portion of the opinion upholding the ACA's individual mandate, was hugely important in terms of federalism and national policy, and also highly controversial. If you found
So, long story short is the Sebelius decision said, no, the individual mandate's still fine, even though it's not fine for the reasons you thought it was fine. And the Medicaid expansion is not constitutional, so you can't require it. So again, January 1st, most things go into effect. Then later that year, there was the Burwell versus Hobby Lobby decision, kind of the second big Affordable Care Act decision in the Supreme Court. The point of this case was we talked about how certain preventive medications, certain preventive procedures had to be offered at no cost, at least no cost at the point of service, and that was, your annual checkup and stuff like that. One of those things was birth control. Needed to be offered at no cost at the point of service. And if you didn't offer that, you weren't an insurance plan. So you had to offer that. Hobby Lobby maintained that it was a closely held organization, which means that the organization functionally had religious beliefs, and that the government couldn't force the organization to go against its religious beliefs. And the Supreme Court sided with Hobby Lobby. It said in certain cases that in certain closely held organizations, if it can be proven that it goes against the organization's guiding principles, then the government can't mandate it. And so Hobby Lobby and therefore other organizations did not have to offer free at the point of service birth control. So then in January of this year, but it was actually passed in 2017. One of the very first things the 2017 Congress passed was it's called the Tax Cut and Jobs Act of 2017. And what that did was, it did a lot of things, but what it did was get rid of the individual mandate. So it said, you are no longer going to be fined at the end of the year if you don't have health insurance. And that's a pretty big deal, because remember we talked about that whole analogy of if you don't include the A students in your pool, you're probably going to go bankrupt paying out the D and C students' test bills. Not requiring A students to buy into that really hurts the ability of a thing to persist. And then in the Consolidated Appropriations Act of 2016 made it so that as of January 2020, there's not going to be a Cadillac tax anymore. So really rich health plans that are offered kind of as perks or in lieu of salary raises to avoid taxation, they're not going to be taxed anymore. So those are the major changes, although this is still live. So last November, a circuit or district judge in Texas basically ruled that the entire Affordable Care Act was unconstitutional. And it's very interesting because the reason he ruled that was because he couldn't have ruled that prior to November of last year. The reason he ruled that was because the individual mandate is no longer in effect. The Supreme Court ruled that the individual mandate was not severable, meaning it couldn't be cut away from the Affordable Care Act and the thing still maintained integrity. So the judge said that now that the individual mandate's no longer part of it, and it's already been established that the individual mandate is non-severable, that means the whole thing is now unconstitutional. That is currently kicking around in the district courts right now. So this is not a foregone conclusion at any point. And also there will be repercussions for the individual mandate being revoked. We don't know what they are yet because it's only been 4 months since that has gone into effect. So kind of putting the changes in timeline back in context. So we want to increase reform insurance. We wanted more people to be insured. However, Sebelius kind of tempered that back a little bit because Sebelius stopped, or at least greatly altered, the expansion of Medicaid. And Medicaid expansion was going to account for a lot of the increased coverage. And also the Job Act of 2017 that removed the individual mandate disincentivizes a lot of A students, so to speak, to not participate. So that more people ideal shrank a little bit in the intervening years. Better coverage. We talked about the Hobby Lobby or Burwell case. That's really the only one. There have been a few other modifications at the margins, but that's really the only big change to what the Affordable Care Act required that insurers and employers cover. And then not a lot of things changed legislatively or judicially for the delivery reform, although a lot of things have proven to be lackluster. I think I mentioned this to someone yesterday, but the Kaiser Family Foundation 2 or 3 weeks ago released like a super long form research article about electronic medical records and electronic health records and the current state of them and the failings thereof. I listened to it on audio, so it was about 45 minutes long. I don't know how long the written article was, but this, integrated care with digital records and stuff like that isn't going as smoothly as we'd hoped in 2010 is a generous way of saying it.
Do we think that's why they're moving into meaningful use stage 3?
I think they're moving into meaningful use stage 3 for a lot of reasons. I think that's part of it, but the meaningful use isn't. So meaningful use, sorry, I'll take a step back. Part of the Affordable Care Act was, when I said we're going to digitize everybody's health records and make things transparent and transferable, the government said, we're going to pay you money. We're going to give providers money to digitize. But if you don't prove to us that you're using your digital records meaningfully, it's been called meaningful use. If you don't use it, if you don't reach meaningful use thresholds, we're going to fine you. So it's a bit of a carrot and a stick, right? We'll give you money to implement, but if you don't use what you actually implemented, we're going to fine you. So meaningful use has gone through different stages. At first, it was gather this bit of information at the end of the appointment. You print out a thing that says this is what we talked about, this is what you need to do at home, et cetera, et cetera. That again didn't always happen. Didn't really happen until 2014. So that was meaningful use, and they've been ratcheting it up a little bit. Why they ratcheted it up again to stage 3, I honestly think it's because, this is my personal opinion, this is not, Kurt the instructor talking. I think it's a combination of, it's a good way to look like you're doing something to solve the problem. The amount of time doctors have spent putting things into computers has not been low, we'll put it that way. About 30% of doctors' times, and this is also in that report, I can email it out to you guys if you're interested. About 30% of doctors' time is dedicated to clicking buttons. According to one study, there's something disgusting like 3,000 button clicks a day or something. Granted, I don't know how many I do a day. It might be more, but either way, my job isn't to talk to patients, and neither is theirs anymore. That's my opinion. It's a good way of looking like you're improving something while making doctors bear the burden. I think most of our challenges as far as EMRs and EHRs are technical challenges, not usage challenges. That's my opinion though. So kind of the results of these changes. There are lots of results. I'll show you some graphs that we're not going to delve into, but I'll show them to you, and you have access to the slides. But the ACA Classic, it was expected that an additional 36 million individuals would be covered by health insurance. So basically, it would go down from 9% of the US population being uninsured to about 6% being uninsured. After all these changes went into effect, it ended up being about 20 to 26 million. So about a third fewer people ended up being covered because of, and which makes sense because the biggest revisions to the Affordable Care Act were in the numbers of people that would be covered. Also, because of some of the tax plans and the changes to how we're going to fund things, originally the Congressional Budget Office estimated that although the Affordable Care Act, the ACA Classic, was going to increase the federal budget by about $970 billion, it would decrease the federal deficit by about $150 billion. So we'd be spending more, but we'd be net spending less, right? Because deficit is expenses, no, inputs minus expenses. We'd have more expenses, but we'd have even more inputs, therefore our deficit's less. That is no longer the case. Again, I just put this here to reiterate a point. I don't know why. But again, we talked about how we removed a lot of access. So ostensibly, cost should either go down or quality should go up. We have yet to see if either of those things is going to happen. I can tell you that as far as the employer market, renewal rates this year, despite the individual mandate being gone, are the same as they were last year. That could be good or bad, depending on your perspective. So here are some results. As far as the costs of healthcare, it's been an interesting mix, right? So the costs of all urban centers has gone down, although this is 2010, this is when the Affordable Care Act was passed. 2015, it started to cycle up a little bit. Let's see. This is the national healthcare expenditures. Again, 2010 it was passed, it started to go down. 2014, all the things started to take effect, so it went up again. Still not as bad as it was in the 90s by any means, or the early aughts. Although our cost percent of GDP continued to go way up. And that's kind of the cost aspect of it. This is the uninsured and budget rate of it. So over here we see the uninsured rate went down quite a bit, which is really good. Like I said, about 9%. It was originally supposed to be about 6% that it went down to. The growth in real costs changed quite a bit, right? So every year, from a family perspective, growth was changing about 6%. After 2010, it went down to about 3%, which is more or less in line with inflation. So that's good. We like that. Unfortunately, this is the sadder part, because as I mentioned, there was supposed to be less of a budget deficit with all the Affordable Care Act classic things in place. So it's supposed to lower the deficit. But ever since 2017, when the tax bill changed and all that stuff, the deficit's basically back on track to increase. So because we've eliminated kind of the taxing and the fining aspects of it, really the only leg that we have left to stand on is reducing payments to hospitals, which nobody wants, or magically everybody becoming healthy again and not using the system as much, which would be awesome. And we'll leave it at that. So anybody have any questions? I know I have like negative 90 seconds to give you, but anything anybody wants to go over?
So would we not be here if it weren't for the Affordable Care Act, definitive health care? Is that like the digitization and all that?
That's a really great question. So who knows what would have been, right? But in my opinion, I apologize. I tend to use a lot of phrases over and over. My very first CEO, not of this company, told me that in a gold rush, the people who make money are the ones selling picks. So I think whether or not there was the Affordable Care Act, this is an industry that needs a lot of picks. When I tell people kind of what definitive healthcare does, This is before we had a mission statement, I guess. But basically, what we do is we introduce, or rather, we reduce complexity in a very complex market, right? Because that's ultimately what we do. You go to one place, you get answers really quick that would otherwise be very hard to get, and then you can act on those answers. That is reducing complexity. And the healthcare market is a massive cluster that we didn't even scratch the surface of today. So I think no matter what, the healthcare market would still be a cluster. People would still want to reduce complexity. We probably wouldn't have, we wouldn't have bought HIMSS because we wouldn't really have had as big of a stake in EMRs and other tech vendors. But again, it's not like healthcare tech didn't exist before. It was just different tech. It was less software, more hardware. So that's my opinion. It certainly doesn't hurt. It certainly doesn't hurt. But again, when the market is change, anything that helps you navigate change is good. And definitive healthcare, if nothing else, helps navigate change. So. Anything else? All right, thanks everybody. Have a wonderful day.